Okay, so hi everybody. So today what we're actually going to do, and Gary and I have already had a quick chat, is to go over the four main types of dementia. Now, we need to understand that there are actually over 100 different types of dementia. And this is why it can be so confusing for some people as to, well, have I got it? I've got these symptoms, but I haven't got that. And this is why making a diagnosis is not simple. We don't make diagnoses, okay? We don't. We're here to support. But for the neurologists too, and yes, they may do an MRI scan, and then they can follow this plan of action here. But then all of a sudden, hang on a minute, a few years later, that bit's not fitting now. And it's maybe not that sort of dementia we thought, yet we'd already been giving you all these certain drugs to fit that particular dementia. And we need to understand that that can be the case. And this is why it can be very scary for people getting their diagnoses, because, well, which one is it? So dementia is the umbrella term, and it is a horrible word because it means demented. Dementia. And that's like, well, it's not really nice, is it? It's really not. So they started calling it neurocognitive disorders. Now, that is also a big umbrella. However, dementia is the word that sticks because it's short and people know it and people live in it and they get it. And they actually, the caregivers, we need to understand, actually, they're the ones that almost feel demented by the end of it. Okay, we really need to understand this. And this is why we're all doing this, to help and support. Okay, so we've got, I've given you a list of various ones already. And the Alzheimer's is disease and is the, I don't want to say popular, it is the most common type. Okay, and it can often be combined. You can get Alzheimer's and vascular dementia, so we need to understand that as well. Lewy body is a little bit of a strange one, and it's people get very confused by it, and it can get often confused with somebody maybe who has Parkinson's. And then there's the frontotemporal dementia. Now, this is not a very nice one. It can come along a little bit earlier than the other ones. You can get it in your 40s. That's quite scary, and your life expectancy is not long. However, it's interesting. So I had a client of mine who was diagnosed with frontotemporal dementia. And I thought, this is interesting, because they've been diagnosed, that was like 10 years ago. They're still alive. And again, something was going on with their meds. I have no idea, because I don't do the med side of it, but their behavior was changing. And I said, please, can you go and see a neurologist again? Anyway, they don't have frontotemporal dementia. And I said, I didn't think you did, because you probably have been dead by now. So they had to, and they don't know which one it is. So they don't know. And it is interesting, as much as nobody likes a diagnosis, we also do like a diagnosis. What do you think to that, Gary? Do you agree with that?
Yes, but it can be not useful sometimes. I get, and in fact, it was Richard Bander, I think, that said it in a case history, sort of somebody coming in to them for depression, and it came in for depression, and he said, well, how do you know you're depressed? And he said, well, my doctor told me. He said, so your doctor's given you a label, and you think you need to act up and be that label. So in some ways that is the case. We like a diagnosis, but quite often once we have a diagnosis, it's unconscious. We seem to try and fit into that diagnosis.
I agree. And so therefore we can have those things, and it's not good, you know. But if you do know that there is something going on cognitively, and then they can't pinpoint what it is, then it's very difficult to know which medication is going to be best for you. And I met another neurologist who was actually met him on an aeroplane, and we were talking about this, and he said, I dislike all the meds that I have to give to my people with dementia. And I said, oh, and he said, because I never know if it's, because we're just still guessing. It's just like trial and error. So I was telling him about what I did, and that I do the hypnosis for people living with dementia, or the caregivers. I'm in North Carolina, so I have to be careful. I do guided meditation for people in North Carolina. And he thought that was brilliant, because he actually then said to me, yes, because they are then getting the right drugs, because they're getting the acetylcholine when their eyes are going left and right. That was the word I forgot last time. I know it really well as well. It was like, oh my gosh, it was quite funny. So it was, and he said that because then they would need less medication. He said, and then they wouldn't have the gut issues, and then they wouldn't need the medication for that, because they've now got diarrhea because they're on all these other things, and then they might get constipation, and then they've got this, and then they've got that, and he said they just end up, literally rattling around. So very interesting, isn't it?
Yeah,
I know. So there's lots we can do as this wonderful profession that we do. So I found that very exciting, and he said that he would be my neurologist in the air, because I met him in the air. So there you go. I may get him, see if he can come join us on one of these fine weeks. Now, so we can go through some of these symptoms, but that was just a quick overview of them all. And there is, what I like is that we can go to the raising awareness of the early symptoms. That is actually more likely when we are going to be brought on board to help people when they say, and I suppose might be same with you, Gary, when you do the people for oncology, when they first get diagnoses.
I mean, it is the whole journey, but it is from the earlier stuff, because mine tends to be from initial diagnosis, probably generally ending with sort of side effects of treatment. I do palliative care, but very little end of life care, because we have a good hospice set up here, and because I'm hospital sort of based. That they go from the hospital to the hospice, so it's rare that I get involved in the later stuff.
Yeah. So it's, I always think if we can get the early bit, that's when we can have the biggest impact, and as well for the caregiver.
Yeah.
Because otherwise, too late in, and the caregivers can sadly lose the will to live. So it's because they're too far down the journey.
Yeah.
Like we we don't cure cancer, we don't cure dementia. We help support. And with the brain health coaching, which we're going to, what are we going to do next week? No, that'll come possibly later. Next week, we're going to do, I've got it here. We're going into the emotions and the reactions next week, what they might feel. And because again, we all know that we can really help with that. So that's what we're doing next week.
Yeah, just looking at my diary, see which weeks I'm here. But yeah, next two I'll be here.
Oh, good. Okay, so yeah, the beginning one's going to be more meatier, but there will be some where we're actually doing some assessments on each other and practicing.
Yeah, the 16th, I'm definitely not here. That's the first.
Okay. Well, as I say, they'll all be recorded, so you can come back. So I think using those are really good, because really, as Dr. Daniel Nightingale says, it's all about turning these frowns back into smiles for people. Now, so again, we know that dementia is the umbrella term, and what I want to go into is the, as I say, the top three are Alzheimer's, vascular dementia, Lewy body. Frontotemporal is still one, but it's not quite as top as the you still won't, you'll still hear the other three more often. So let's look at the symptoms. Let's go one at a time. Let's go look at the symptoms of vascular dementia and the characteristics. So often we will have the immediate, the challenges with immediate working memory, which will mean that people are forgetting their appointments, dates. They're forgetting if they've made a hair appointment, and they're even then forgetting to put it in their diary. They're forgetting that they've got a vacation coming up, birthdays. And it's usually the short-term ones. So it's usually an appointment, first of all.
But this is the Alzheimer's, not vascular.
No, this is Alzheimer's.
Yeah, you said vascular when we started.
Oh, I apologise. Thank you.
Because I thought, oh, we're not starting at number one, we're starting at number two. And I turned my page over.
I'm keeping you on your toes just to check that your working memory is good.
Yeah, I'm all right this time of night. A few hours time, possibly not.
I can always get away with something. At least I can laugh at myself. Okay, so every single time I do something on here, though, I will make a mistake. All right, just be aware of that. And sometimes I will say this. Sometimes I do it on purpose with a client. Anyway, I want you to be aware of this, because actually it is important to be able to laugh at ourselves, and when we are with a client living with dementia, to make the odd mistake.
Yeah.
Because that makes them feel more comfortable. Because it's normal to make mistakes and forget things.
Yeah.
So I am not a perfectionist. You will find that out pretty quickly, and that's okay. And that's what I want for our people living with dementia as well. It's okay that they may bring you a cup of tea over if you're there, and they've forgotten actually to put any tea, it's just hot water. It's okay to, if you've asked for no sugar and they've put 2 sugars in it. It's okay. You know, we've got to sort of like just normalize some things, because we can all do them. But I don't, because there's nothing worse than saying, what did you do that for? You know, it's like, so sometimes, and I do this actually anyway, I'll say this within my own clients. I don't know if you do, Gary, who are perfectionists. I do see a lot of people with perfectionist issues because they're people pleasers from their childhood. And we will see these clients with this issue as well. And this is why they can get so angry. It's because they're so angry with this disease, if you like, and they're being not perfect. So this is the kind of thing that we will be battling with, which is why I often, as you will find, I make mistakes to remind everybody it's okay. And I do that with my perfectionists because, and I go, did that bother you? And they just go, no. I go, see, it just doesn't matter. And it gives them grace. Then they can start giving themselves grace. Does that make sense?
Yeah.
So actually that was almost useful, because I really did want to say that as well, but it's not written anywhere. It's just something that I know. So there you go. I probably made that mistake subconsciously. So yes, disorientation to time and place. Yeah, you know, it really can. I mean, you've got all of these on the list here, but it's and I don't know. My husband will often ask me questions, and I just think, you only asked me that like not long ago. I must admit, I am getting a bit worried here and there, because I'm like thinking, oh my goodness, because I'm very aware of it. I also know that sometimes this can happen when people don't listen properly, when they have selective hearing.
Yeah.
and and he is thinking of something else when he's asked me that the first time. So again, it's not always. All right. So look for the behaviors. Look. So we have to check these things. However, the inability to follow a simple procedure, such as making a cup of tea, like I said before, they're bringing you a cup of tea and there's no tea in it, it's just hot water. Or have they, so it's those short-term things. They've asked you, do you want sugar? And you've said no, thank you, and they bring it with 2 sugars because that's how they take it. So they've gone, oh, you must like it the same as me, even though they'd heard that no sugar.
Yeah.
So it's that kind of, those little things for people. Now, like I said, because I don't want to just read off the stuff that you've got here, because that's just boring. You've got it already. So it's the cause of Alzheimer's is still unknown, still not known. However, they do believe that it is the neuritic plaques and tangles that are the cause. And it's, again, because there's new people getting their new PhDs all the time. So it's now, that's controversial as well. So we can always, as much as we learn something 1 year, 2 years later, it's not correct information anymore. And I expect, do you find that in the same with the cancer field, Gary?
Not so much, because I don't tend to study a lot sort of the cancer. I tend to look more on the hypnosis and the complementary therapies research around cancer rather than the cancer stuff itself.
Yeah. So, and same here.
Yeah.
It's, well, what can we do? So it's like, so I just go, oh, they're doing that now, are they? But there's nothing changed. People are still going through their issues.
Yeah.
So you're right. You're actually quite right, Gary. We don't really need to know that, but it is helpful. The reason why is because you're going to get asked it.
Oh yeah. Yeah.
They're going to think
Yeah, I mean that's what I always say in hospital when I was seeing people in hospital on teaching in my training is you need to know the jargon, you need to know the background in the cancer and the treatments and stuff like that. Because especially if you're based in a hospital, you're another expert. So the oncologist says, "Oh, go and see the hypnotherapist," and because you're in the hospital, they assume you're another expert. So they'll sort of wander in with their case notes and saying, "Well, I've got grade 3 breast cancer, stage 2 on Herceptin," and if you look at them blankly, you've lost them.
Exactly. You have to have an overview of these words,
Yeah.
just to give them that comfort that they're safe and secure in your hands.
Yeah.
As you say, it's almost a little bit of play acting sometimes. Well, it's not, because you're learning it now, okay? But with some of the new drugs, I mean, I can give it in another session. We'll go over a list of drugs we'll come across. Of course, they may be different in England.
Yeah, could be, yeah, brand names and so on.
So it's so that's so I might not be able to help you so much on that one.
Right.
But the I just want to say that we do know that there are a number of factors that increase the risk of developing Alzheimer's, and these can actually include Down syndrome. I don't think that's on the sheet I gave you. Down syndrome, diabetes, and you may have already now heard that clinicians are referring to Alzheimer's as diabetes type 3.
Okay.
So I'm not sure if you've heard of that yet.
No.
So it's the type 3, or diabetes, if you like, is Alzheimer's. Again, obesity. And there is there's a big word here, and it's an individual's apolipoprotein status, which is spelt, are you ready? APOLIPOPROTEIN Poprotein. In fact, I bet you can say that better than I can, Gary.
Protein. A polypoprotein. Yeah, it seems to be.
A polypoprotein. Yeah,
Yeah.
status. And it's that, again, we don't really need to know that, but that is an individual's select thing. So people with these things may be more subject to getting diabetes. And we all know that obesity is massive. Literally.
Yeah.
There is it's an issue. And so therefore, again, as hypnotists, we can help people with that.
Yeah.
And we can, and sometimes it's literally just, you know, and I do use this, I don't mind saying, I'm sometimes not always very kind, but if we've got people sitting on the fence, and I'm like going, well, you know that you could of course always get type 3 diabetes, and they go, well, what's that? And I go, Alzheimer's. And I go, and then this could happen and that could happen. Oh, well, I'm already, and oh, well, so you're drawing people more to their discomfort place so that they're more in the place of getting motivation to drop the weight off. I did that with somebody, actually, it sounds really mean, doesn't it? But I tell you, he stopped his sugar addiction in the first session. And then I had to clear his other things that he had going on. But he's been a year no sugar, and he has dropped 60 pounds.
Oh.
And because I did one of these tests on him because he'd already had a stroke, and I use anything I can to create change. Hey, and it worked.
Cool.
He's healthy. So, you know, if we can, I mean, obviously I did it in a kind of nice way. I wasn't mean. But it's just about having that kind of authority. And then they're like going, oh, okay, I don't want that. And this just gives us another place of authority to help our clients create change, to become healthier so that they live longer. You know, people come to us for change. So it's like, well, we can do that however we can. Is it manipulative? Probably. Okay. Now we've got, let's look at vascular dementia. And I always find the vascular dementia really interesting because, and here it says, you know, you've got your notes on it about the stroke, and the more strokes that somebody has, unfortunately, so that's more of the little ischemic attacks that they get, and then that's all the time reducing the blood flow, and so they're more likely to get vascular dementia, or again a combination of the two. So it's pretty, you know, it's scary. Again, you see, vascular dementia we can prevent. It is, and this is one that where it's healthy living. And we all know that smoking can bring on a stroke. We know that not exercising, that drinking too many beers with Gary Coles is bad for you.
Yeah, I can say you got me on that one.
So actually, well, you know what? If maybe you need to hear some of this, you know, we all do. It is literally, it's like, well, what can you do? What can you do to prevent it? But you know, when you look at the symptoms of early to mid vascular dementia, again, it's some of them, they do, of course, they overlap because it's the challenges with the immediate working memory and the short-term memory, but it's difficulty with concentration when you lose focus. And again, then you've got people going, well, I've got ADHD now, or I've got menopause, or I've got what do they call it for male menopause? There is a word.
Oh, I didn't know that.
Did you not? Oh yeah,
Uh,
the men can get there's a male menopause. I was just talking to Kaz
yeah,
Randall the other day.
yeah. I mean, I know they say about the male menopause, but that's all I've ever heard it called as
Mm,
over here.
there is actually a word, and I've forgotten it. There's going to be a lot of
But
things.
it's not likely to affect you, is it?
No, it's fine. It's probably why I let it go. So that's fine. But it's so yeah, so it's difficulty with concentration
Yeah.
again, how that is really tricky to to quantify. However, over a period of time, I think anybody would notice if they literally cannot concentrate for long on a certain task,
Mm.
whether it be ironing or watching TV or reading a book or whatever it is. And again, it's disorientation to time and place. So this is again, we've got and the impaired judgment, slowed thinking, a clumsiness, and then some people are more likely to get that horrible, I suppose, sleepiness, apathy. It's a
Mm.
horrible word, isn't it? Apathy, and can feel depressed and down. So again, there are so many things that are mixed in with other stuff. So it's really hard to make this, but fortunately we don't make the diagnoses, but these can be the symptoms. So we always get, so I want us all to realize with this, for me, the main giveaway I want everybody to take today is to get curious. Okay. If you come across a client, not that we diagnose, as I say, but if we have a client or they have a family member, then we get curious and we can start asking a few more questions. And what else are they noticing? What else? Not necessarily just, oh, what else have you noticed? And every time you're seeing them, so it's it, because sometimes again, I don't know if there's going to be a knockover effect with people having cancer treatment and say on certain drugs that then that leads to short-term memory. We don't know, but of
Yeah.
course there's definitely depression and apathy with cancer, somebody living with cancer, and fear. So there's going to be a lot of there may well be some overlap with some of the symptoms.
Yeah, I mean, one of the ones that some of the drugs and that do now, I get a lot of people with what they call brain fog, which sort of covers all that type of thing.
And I tell you what, COVID,
Mm,
there is COVID brain,
right.
and we can help with that as well. So we're doing an overview of some of the things that, because we will meet somebody and they would have had the diagnoses. We don't diagnose. We would then go back and go, oh, which one is it? And you then just a little, the names like you do with cancer. You have to be aware of the names, and you have to be aware of what could potentially be the issues. Now, if we go to Lewy body, there are symptoms again, as I say, with Lewy body, the symptoms can present the same as Parkinson's. So you've got the tremors, the small handwriting. Small handwriting can be and I don't think that's in this one, the one that you've got, can show a potential sign of Lewy body. And loss of smell. And then I think one of the scariest things for people with Lewy body is the whole thing of is the hallucinations.
Mm.
Because what happens, and actually, I'm going to say this as well, is that what happens with a lot of people, they might not have Lewy body, but at some stage in pretty much every dementia, I can't say for everyone because I don't know, but a lot of people will get hallucinations at some point.
Right.
And then it's, how do we handle that? And this is and that's where we come in really helpful for the caregivers, because the natural instinct is to say, there's nobody there. No, there's nobody there. Well, there is to them.
Yeah.
And I don't know if on any meds with people living with cancer, Gary, people have hallucinations, do they?
I've not really come across it. I've had a couple of cases, but that's normally been sort of side effects when they're coming out of general anaesthetic, and it's reacted with them.
Yeah. And then we also have to remember that some people, as they are passing away, will see people. And again, they really may be their soul people coming to help them. We don't know. Nobody knows.
No,
nobody knows. I believe one of the worst things we can do is to say, no, there isn't, and that they're wrong, because that in itself can cause issues.
Yeah.
So it's much kinder to say, are they nice people or are they horrible people? And if they're nice people, would you like them to stay or would you like them to leave? And if they're horrible people, would you like them to leave? Because obviously we don't want horrible people to stay. And they go, okay, I'll get rid of them. And then literally you make believe, like we did when we were children, because I bet you, you like me, we probably played imaginary friends and did, I remember pouring a cup of tea, fake water and having cups of, whatever, and there was nothing in it, pretending to eat something or whatever it was, or, and you just play along.
Yeah.
So you play along, and I mean, there were no real, if you were playing cowboys and Indians, it was just bang, 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 you were killing people, there was nobody there. It's like, it's all, sometimes the thing can go back that way to back to child. So we showed them the door. Right, I'm going to get rid of them. I'm going to get rid of them. I had this with a client, and she, it was quite interesting. So her previous job had been as a caregiver. So do you remember, and I really wish they'd never got rid of them in England, the ladies who were, they weren't the nurses, but they were the other carers they did all the other jobs that the nurses didn't do. And they got rid of them all. I never know why. But she was like one of those. And so actually you do an awful lot of caring, holding the hands and things like that, and being with people. So she was a caregiver in the hospital, and she had dementia. I was going to a house, and she said, and I wasn't allowed to sit on the sofa because all the other people were on the sofa. Okay, so I had to sit on this hard chair. And then there was this other chair, and that somebody was in, and it was like, okay. And I'd say hello to them. And then and she said, he's just taken his eyeball out. Okay. And I'm going, oh, okay. I said, does he need it put back in? So we play along. Okay. I mean, it's just the most bizarre thing. And I said, are these all people that you've looked after before? And they were. So we get curious. You see, we always get curious. What is going on? So these were all the people that she'd looked after. And now they were there. And then she started fretting, I haven't got enough to feed them. I haven't got enough to feed them. I said, shall we ask them to leave then and go to somebody else's house? So we did. They went to somebody else's. And just went with her. But the son was going, like, he couldn't handle it. He's going, there's nobody there. And he was screaming and shouting. He had been screaming and shouting at her, which of course was getting her, there are. And it's just like and more fraught. I had to say to him, just go, shall I show them out? You know, or I'll go shopping now, I'll get them some food or whatever, play along. And he goes, I can't do that because it's not real. And I go, well, do you want to argue with her and get her angry? Because you never win an argument with somebody with dementia. You never argue. That's another one. Never argue with somebody living with dementia, because you can't win. There's nothing to win. And it's, I said, you can either do that and get her crying. I said, it's your choice. You have to be like that sometimes with the caregiver. Yeah. And he was a big dude, but I just went, you have to be whatever. And he was like, okay. And then he did that. And then as soon as the people arrived, he showed them out, and then it was gone. It's just it all stopped. So interesting, isn't it? How much better that is.
Yeah.
The argument, which then went on all night, and she would go to her room crying. Well, that's not making happy little faces, is it? So that's horrible. So we just so that is really important. That's what we do with people when they're having those issues. Again, sleep disturbance is huge. Mobility challenges with people with Lewy body, they fall a lot. And this is, again, when they can end up getting fractures. So they get, because they fall, because they can't do the spatial awareness so well. Now, this is why sometimes when we have, there's that awful word, I think I used it in my talk, wandering. They use that word, that people are wandering, and they're never going to get away from it, because actually, as opposed to people, they do wander. They wander off, but they're walking with purpose. I think that's what I said in my talk. They're always walking with purpose. So, however, we do not want somebody living with a Lewy body or any dementia wandering off and leaving the house and then getting lost. So these are some useful things that we can do. Being aware if somebody has a Lewy body diagnoses, we can advise the caregiver to put a black mat in front of the door, because the person with the Lewy body will think it's a big black hole.
Right.
Interesting, isn't it? It is also just as upsetting for that person to go shopping with you, and if you're in a shop and there's lots of big black marks, they will think there are holes all over the place. So some places have patterned squared flooring, like a checker, like a chessboard. That would be awful for them, because they would have to walk on all the white spaces, because otherwise they're going to be falling through all the black spaces. Can you see how upsetting and distressing that would be for somebody?
Yeah.
Yeah, you see? Isn't that freaky? You wouldn't think it, would you?
No.
So all of those little things we need to be aware of. And that, again, is, and we'll be doing another session on this about going to people's houses to make a house assessment when we see somebody. Have you got any questions so far?
Nope, not so far.
Is it all making sense?
Yep.
So, and then the frontotemporal one, again, as I think I said, I've already said that sadly that can get really early on. and people can get aphasia, where they can't speak. Now, this is very interesting because although somebody can't speak, they can generally still sing.
Mm-hmm.
Because it's in a different area of the brain. It's in the Brox and Vernix area. So actually, we could, and I don't know for sure if this is it always works with everybody, but somebody could try getting them to sing, or just sing along with them something and then see if they can. So it's not a test, because we don't test people living with dementia, because that is that's not very nice, is it? But again, you know, early symptoms, my goodness, 40 to 65, it's just so scary, you know. Compulsive or repetitive behaviors, you've got all this in front of you. You know, just difficulty naming objects, lack of, yeah, and then it's the characteristics that we might find. You know, say if you've been married for a long time and then suddenly the behavior, they're suddenly becoming mean and nasty and lack of empathy, and they used to be so kind before. That's horrible. So the whole thing is just horrible, you know. And this is what we need to really understand for people. So what can we do? What can we do? And therein lies the whole thing of you know, equipping them with tools and techniques, and of course that good old wonderful word, the opposite of stress, relaxation.
Mm-hmm.
That's what we're really good at doing for people, because if they're getting lack of sleep because of worry, because of whatever, and we all know that like 20 minutes of hypnosis is like having 3 hours of sleep, and that's so important. Has that ever been proven?
I've not seen any research on it. I should, that's something I should have asked last weekend at the UK conference.
That would be quite, yeah. I mean, has that actually ever been proven? I
Yeah,
know I always feel something.
because obviously I had a one-day workshop with the right person to ask. So
I know, that's so cool. So yeah, so it's but we need to I think raising awareness of the for people in general everywhere, and in shops, just looking around, being kind. There's because you can just tell sometimes if somebody's say looking a little bit vacant. I know I've often helped people in a shop, you know, when they're food shopping, they can't find what they need. I'll go, can I help you? And I'll take them to the right aisle, because there's never enough staff nowadays, or especially not in America. And you know, because we can, and people get confused, and or they go and they forget what they're getting. They might have a list, but they for some reason have forgotten to read the list, or whatever they're doing. They just literally can forget in that moment. And all it takes is if somebody's a little bit kind, and then it can bring them back. That's all it takes.
yeah.
Just bringing the person back with a smile, somebody being kind, and then it takes you away from fear. So this is why that's always important. I'm going to read some facts. So because people living with this type of dementia can fluctuate in cognitive ability from one moment to the next. So here's a fact. It is very common to have mixed dementia, and this is both vascular dementia and Alzheimer's, or Lewy body type dementia. So wow, you could have all three. Fact, in the UK, there are 43,000 people at working age under 65 with a form of dementia.
How many was that?
43,000. And it's 200,000 in the USA. That's a lot of people with a form of dementia under 65. So that's scary.
Yeah.
Now, in the UK, there are 850,000 people living with a form of dementia. In the US, there are over 5 million. In Canada, there are 564,000. But I wouldn't be surprised if that was nearer 1 million now in the UK since this information. Now, this is another interesting one. There are 1 in 150,000 children with a type of dementia. That's too many. And it is called, and this is very rare though, Niemann-Pick's type C. So the Niemann is spelled Niemann.
Okay. N-I-E. Yeah. Niemann.
Niemann. Pick's apostrophe C. So P-I-C-K apostrophe S, sorry, and then type C. And this can present at around the age of 10 and is like an Alzheimer's disease. It is my understanding that generally a child will generally die before 25 if they have that. Doubtful we will ever come across that. They diagnose it. They never seem to get diagnosed way too late.
Yeah.
And by then, like, it's like literally the kid is at school, can't go to school anymore, is at home, starts obviously getting could potentially get very violent, sad, but then they lose that ability. Then they lose, they can't talk, and then literally eventually they'll get the diagnoses, and it is Niemann-Pick's. But it's isn't that awful? It's terribly sad. So another fact, according to the Alzheimer's Disease International, someone in the world develops dementia every 3 seconds. Isn't that scary?
Yep.
So it's so that's those 4 main ones. And as I say, you've got, I gave you a sheet to anyway, so I didn't want to, I'm not going to read it off to you because you've got it.
Yeah.
I just wanted to add to it. That's
which I have.
Yeah. And yeah, good. And that's what we wanted. Okay. So it's and then because I want this to just be in like little small chunks.
Yeah.
Because to me it's easier to embrace and and to go over and really get this down to a pat. And then, as I say, if you can, you will soon start to get a client with it, because the nature is you learn more what comes your way.
Yeah.
By the sheer nature of life, you will say, I can help with that.
Yeah.
And you will be able to start helping the caregiver and the family because you can.
Yeah.
And we'll be going through all of that what you do. But right now we're doing the some of the background stuff.
Yeah.
So I know if we'd had somebody else on here, she would have been asking other questions or sharing. So because that's what would have happened. Have you got any questions on any of that?
No, I can't say I have.
Do you know of anybody with any of these issues?
Currently, I don't think I do, to be honest.
No,
No.
no.
I mean, my dad's in a care home and he gets a bit confused, but I don't think there's anything like that going on. I think it's just old age confusion
There is,
and not hearing, not
yeah.
hearing well.
And I tell you what, actually, hearing is, you're quite right, because when
Mm,
people can't hear, then they become disengaged.
mm,
And I'm glad you mentioned that, because actually that is one thing that is really important to make sure he does get to do, is to hear.
yeah.
Because the less he hears, then the more likely he will start to not engage and feel lonely.
Yeah, no, actually, since he's been in a care home, he's been just about a year now, and it seems to be loving it. I mean, when he was at home, he wasn't eating, he wasn't doing anything, was sort of quite tearful, and he's now in a care home, and he seems to watch sport all the time, apart from when they're doing things. When he got there, they were saying, oh, we do things like flower arranging, and we make models, and we play games, and it was, I don't think I'll do any of that. But every time I go there, I can never find him because he's off doing some sort of
Brilliant.
thing or game
Okay.
or whatever.
Right, brilliant. So his hearing must be good enough then.
Oh, with hearing aids, yeah, that
Okay,
is.
okay. So yeah, so always make sure that those are good.
Yeah,
Okay. In
yeah,
fact, but for any of us, if we find that happening, make sure that if hearing is starting to be impacted,
mm,
that is one of the first things that we need to make
mm,
sure is right for our clients, that they're hearing,
yeah,
because otherwise they get disengaged, and then the loneliness because they can't follow conversations,
yeah,
and then therein lies their brain isn't working, and therein lies they start getting depressed, and they can go just downhill.
yeah.
So it's so good. I'm glad he has that. That's wonderful.
Yeah, no, he seems quite happy now. So
Yeah, because loneliness kills.
yeah,
It really does.
mm.
So it's important to have people around you. So I really like that. Okay, so we'll probably finish a bit early then today, which probably suits you.
Yeah, because
You've got to
I've
go
got to
off,
set
and I'll
my
just,
one up.
and we finished anyway, and I'll just be sat here talking to myself.
Yeah.
But
Yeah.
that's
So
fine because yeah,
yeah, I hope my guest turns up and hopefully we get more people. I get a similar thing. I got 50 people signed up for the mentoring, but I mean, on an average, and admittedly, some are in Australia and New Zealand and various other things, but I mean, quite often I'll only get 3 or 4 actually turning up to watch it live,
I know,
which is a bit of a shame with some of the speakers I get.
yeah, and it is because actually you do want to have a a full thing.
Well,
So
yeah,
I'll
I'm hoping there'll be a big turnout tonight because I think it's probably my best, well, my highest profile guest of the year.
oh
So,
good, all right,
so
okay.
we're doing a thing on using the Elman induction online
Oh
is the
nice.
theme tonight, and we have Cheryl Elman doing it.
Oh, do you? Oh,
Oh
cool.
yeah,
Okay.
so, yeah,
I was just on the phone to her earlier on actually. So yeah. So
yeah,
I
yeah.
text.
No, she is my guest lecturer tonight.
All right, because she was going to join me on Saturday for the bunny talk. So, but because
Right.
she's trained in it, but I've said to her because she was going to help me with the breakout rooms, and I said, don't, you've got guest. I said, do your guest. I said you don't need to help me. Anyway, so I'll see you on Saturday in any case. All right, but
Yep.
I'm going to pause. I'm going to